Hi everyone, thank you for joining us for today's webinar, Shingles, What's New to Know. I'm going to go ahead and mute all participant lines, and then we'll begin our webinar.
The leader has muted your line. To unmute your line, press #6.
Good afternoon, everyone. My name is Morgan from the New England QIN-QIO, and I will be your moderator for today's webinar. The New England QIN-QIO works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. So with that, I want to thank you for joining us for today's webinar. Before we get started, I wanted to go over a few housekeeping items. This call will be recorded for training purposes, and I'll provide you with details on accessing the recording at the end of the webinar. As I mentioned, the phone lines are now on mute for the duration of the presentation, but if you have a question throughout, you can pose it in the chat box at the bottom right of your screen. Please make sure to send your question to all participants so that we can keep up with the incoming questions. At the end of the presentation, we will open the phone line for questions, and I'll give you instructions at that time how to ask a question over the phone. If you haven't had a chance to download the slides for today's webinar, I will put the link in chat again. And with that, I will turn it over to Russ Cooney from the New England QIN-QIO to get us started.
Good afternoon, everybody. I have the good privilege of introducing Dr. Gravenstein. He is a professor of medicine and professor of health services policy and practice at Brown University, and adjunct professor of medicine at Case Western Reserve University. He's completed the internal medicine residency and geriatric fellowship at the University of Wisconsin-Madison and William S. Middleton Veterans Administration Medical Center, where he joined the faculty and was tenured prior to leaving for Eastern Virginia Medical School. At Eastern Virginia Medical School, he became the John Franklin Chair of Geriatrics, Director of the Glennon Center for Geriatrics and Gerontology until being recruited at Brown University in Providence, Rhode Island. There he became Clinical Director of the Centers for Medicare and Medicaid Quality Improvement Organization, Health-Centric Advisors, which oversees quality improvement work for CMS throughout New England. He also has served as CMS independent adjudicator of disputes arising from federal nursing home survey disagreements for most of the last 6 years. Academically, he has been a clinical educator and researcher since completing his fellowship in 1987. He has enjoyed uninterrupted competitive and non-competitive funding since completing fellowship, with a primary focus in immune senescence, vaccines, and aging, emphasizing the long-term care setting and relating to influenza in addition to separate work in quality improvement and care transitions. Before I bring on Dr. Gravenstein, I want to update the disclosure information. Dr. Gravenstein does some consulting work for Merck & Company, which makes and sells the live Herpes Zoster vaccine. With that, I will pass it on to Dr. Gravenstein. Welcome.
Good afternoon. Can you hear me?
Yes, we can.
Perfect. We're going to be talking today about shingles and both what it is and why we should care, and the new vaccine that was licensed just in the last year for its prevention. So we'll go over the ACIP recommendations and evaluate treatment choices for shingles. So let's start off with the polling question. The question here is, if an administration error occurs when vaccinating an individual, you should immediately report it to, and you can choose any one of these. Jennifer, please open the polls. You can choose vaccine adverse event reporting system, vaccine error reporting system, or both. Please choose one, and then click on submit. Okay. Do I advance it to get to the graphic?
No, we just have to wait a few more minutes for the results to pop up. Sometimes if people don't actually hit submit, it gives them a little bit more time. So just bear with it for a few minutes and the results will pop up.
And you said minutes. You meant seconds?
I meant seconds. I apologize.
Okay. All right. You can see the polling answer here for most of the answers are no answer. So we'd like you to participate because this helps us understand where we need to spend our time teaching. So when you have an error in administration, this is not an adverse event. It's a vaccine error reporting program. So that's where you report that. If this had been an adverse event, you would use the VAERS system, but for administration, when you have an administration error, that's a verb. Okay, let's go to the next slide. So polling questions here again. Local or systemic side effects for Zoster and Shingrix? Jennifer, you can open the polling again for this next question, please. So you get to choose here, have the same or similar impact on the individual. Zoster side effects can be more impactful. Shingrix side effects can be more impactful. Your answers will be anonymous, so again, it's helpful to us to know what you know because it'll improve our educational activities.
Dr. Gravenstein, while we're waiting for the answers to come up for this polling question, we do seem to have somebody who's not muted with a little bit of wind in the background. So if you could please mute your line by pressing *6 or using the manual mute button. Dr. Gravenstein, if it gets too distracting, we can remute the phone line. There's just a little process behind that. So let me know if it's distracting to you.
Okay, thanks. All right, the polling answers have come up. Again, 57 people didn't respond. I'd appreciate if you would respond to these because it helps us. The second most common answer was have same or similar impact on the individual, and about evenly split between Zoster being more impactful versus Shingrix. With the discussion that follows, I will tell you that in terms of serious adverse events, the kind that lead to hospitalization, they're actually similar. But if you're talking about grade 3 effects, Shingrix has more of these grade 3 effects that take you out of commission for a day or two. There's folks in the background that need to be muted.
Dr. Gravenstein, I'm going to go ahead and remute the lines. To do that, I have to unmute everyone and then remute everyone, so bear with me as I do that. Okay.
The leader has unmuted your line. The leader has muted your line. To unmute your line, press #6.
Okay. Can you hear me?
Yes, we can. Thank you. I'm sorry about that.
So the polling question again, the answer I was looking for was Shingrix side effects can be more impactful, and that's because after you get the vaccine, 17% of the people will have grade 3 moderate side effects. 10% of those moderate, 10% of people who get this have a pain that's significant enough to keep them from using their arm for a day or two. You should know that folks come in for a second vaccination, even if they had moderate side effects, they still came in for their second round. So it hasn't prevented people from using Shingrix. All right, so the next slide is what is shingles? And I suspect most of our audience already knows this. Shingles is caused by a virus. It's called varicella zoster virus. The way varicella zoster virus gets in your body is typically when you're a child, you get infected with chickenpox. This is the same virus that causes shingles. You can also get this virus from a live virus vaccine. Once that virus infects you, it becomes what's called latent, meaning it doesn't cause any additional symptoms, and resides in the dorsal root ganglia, which are next to the spine. And it sits in those nerves dormant until some later life stress causes reactivation of virus. When that stress occurs, the virus starts replicating, and it moves its way down the nerves to the skin in the same dermatome that the dorsal root ganglion is in. So typically you'll get this reactivation, and you'll get some pain and other symptoms which are followed by a rash. I'm going to have some more slides on this in a moment. In this slide you can see a chickenpox rash on the right and a shingles rash on the left. So the chickenpox is typically in a kid, and you can see it's on both sides of the body, whereas the shingles rash is typically on one side of the body. So when this begins, often they'll have pain for anywhere from a few days to weeks. When I've seen these clinically, they come in with nondescript pain, but it's like if it's on their chest or something like that, there isn't anything that seems to help it. It's not made worse by movement, but they have this throbbing or stabbing or burning pain that they can describe, but there isn't anything obvious to help you with the diagnosis. We end up doing sometimes tests looking for a source, sometimes even for heart attacks or things like that. But these tests come up negative, and when the rash appears, we go, oh yeah, so this was shingles. The rash is typically a little bit of redness first, and then some blistering. Macular, papular, vesicular, the vesicles start off clear. If they, as they mature, they can turn yellowish and eventually break open and scab. And if they're not clean, you can get an infection in the skin in that area. So these are always along a nerve pathway. They're typically unilateral. In some immunosuppressed people, they can be on both sides. Trunk is where I've seen them most often, but also on the face. And you can see the example here in the trigeminal nerve, the upper branch, it's on the forehead on one side. These vesicles will dry and heal in a few weeks. They can come, and the pain that they have beforehand can also come with fever, headache, and if there's involvement of the trigeminal nerve, and there can be photophobia, and even if not, there can be nausea. So the complications after this rash, some 15% of zoster, of herpes zoster will have zoster ophthalmicus. 50% or more can have post-herpetic neuralgia. The risk factors include advanced age. The more severe the pain is, the greater your risk for post-herpetic neuralgia. It can begin before or after the onset of the rash, so if you just have the premonitory symptoms, you can start having pain that doesn't go away afterwards. It's more likely the more extensive the rash is, and it's more likely when the rash includes a nerve in the trigeminal or ophthalmic distribution. So the ophthalmicus is specific to the ophthalmic division of the trigeminal nerve. If it's untreated, half to three-quarters can cause acute ocular complications, and those can ultimately lead to blindness. So this is a thing where you'd like to have an ophthalmologist involved. The complications you get from this include myelitis, encephalitis, including meningoencephalitis and ventriculitis. You can get cranial nerve palsies. You can get something that looks like an ischemic stroke. When you get the zoster, you can also have a zoster viremia with broad cutaneous dissemination. So it may start off unilateral, but eventually become bilateral. You can get pneumonia and hepatitis, and you can also get DIC. The most important dermatologic complications are secondary rash infections. That's probably the thing I see most often. And if they get infected enough, you can get permanent scarring and changes in pigmentation that last. So there's various definitions for post-herpetic neuralgia. It depends on which paper you read. The one I think that's used most often is if there's still pain that persists 30 days beyond the onset of the rash. Some people use 60 or 90 days. This occurs in 18 to 30% of zoster cases, more likely to occur in older people. This is typically described as mild to excruciating pain after the rash is cleared. It's described as constant. In some people it's intermittent or with trivial stimuli. So, for example, if it's on your face and you get a cold breeze and that's where you had your rash, it can cause pain syndrome just with that stimulus or stroke of a finger or something like that. Some people will have this for months or years. And it can be pretty debilitating, disrupting work, sleep, mood. It can cause impairments in activities of daily living where they can't do regular tasks anymore. And it can cause social withdrawal and depression. So this turns out to be a pretty important complication. So who gets the shingles? First you have to get chickenpox or varicella vaccination. Varicella vaccination, again, is vaccinating kids to prevent chickenpox. By the time you get to be 40 years old, you're 99% or more likely to have had chickenpox. So virtually the entire 40-year-old plus population is at risk for getting zoster. You can get it at a younger age too. The most important risks for herpes zoster are related to a problem with their immunity, and the 4 biggest conditions are age, so just by getting older your risk goes up. Medical conditions, especially conditions that can stress your immune system like cancer or HIV. Medications that you get for cancer like chemotherapy and radiotherapy. Immunosuppressants like steroids and medications for rheumatoid arthritis. And plain old ordinary stress, if you have a severe life stress, divorce, losing your job, things like that. That can also be a risk specific to getting shingles or herpes zoster. So who's at greatest risk are the people with compromised or suppressed immune systems, such as those with cancer, HIV, organ transplants, and immunosuppressive medications. So why should we care? Well, before the era of vaccines, we were getting 1 million or more cases each year, and our lifetime risk for getting shingles was about 1 in 3. The age increases the incidence, so in children it's about less than 1 case per 1,000 children, and for folks 80 and older it's more than 15 cases per 1,000, and if you're living in a nursing home, your risk is 15 to 20 per 1,000. 10 to 18% of adults will go on to develop post-herpetic neuralgia, and that risk for PHN also increases with the risk of herpes zoster and with age. So let's talk a little bit about the vaccine options. Presently, there are 2 vaccines out there. One of these is the live zoster vaccine. This is a live attenuated virus, so it's designed to not cause shingles and prevent chickenpox. And kids who get this vaccine for chickenpox, it's not called the zoster vaccine. It is a identical virus, but in shingles, it's 14 times greater dose when it's the Zostavax. And it's given as a single subcutaneous injection, and in the picture you can see they're pinching up the skin to make sure it doesn't go in the muscle, and it's injected into the subcutaneous space. The other vaccine, of the 2 that are out there, is the Shingles vaccine. This is a recombinant zoster vaccine. It's given in 2 doses, intramuscular. The first dose is given at least 2 months before the second dose. And the way it's been licensed has been the second dose should be given 2 to 6 months after the first dose. The Shingles vaccine is different in a couple of important ways. First of all, there's nothing alive in the Shingles. It contains 2 adjuvants, monophosphorylated lipid A and a saponin QS21. These 2 adjuvants together with a recombinant glycoprotein E generate both a T cell and an antibody response. So you get CD4 positive T cells and antibodies, and the adjuvants push the response to this specific glycoprotein E antigen. The glycoprotein E antigen is something that is in high concentrations in the skin. It is on the surface of a virus when people get shingles, and it's the thing that you make antibodies to that can prevent the shingles from spreading. The glycoprotein E is also a really important component of the virus that helps it get into cells for initial infection and spread from cell to cell to give the broader rash. So here's the next polling question. Storage requirements for Shingles requires vaccine to be kept in which of these? Jennifer, please open the polling. Please try to answer this question. Remember, it's anonymous, so there's no harm, and it helps us know, again, where to spend time on education. So the choices are in a refrigerator, in a freezer, at room temperature. So thank you for answering that question. The correct answer for this is in a refrigerator, and 53% of you got it right. Still, we're getting 28% without an answer, so good for you. The live vaccine is split between freezer and refrigerator. We'll go over that in the next slides. So the route of administration, the Zostavax, the live vaccine is given as 0.65 milliliters as a subcutaneous dose. And what happens is you mix the two components together and administer it immediately after that so that you don't lose potency. After 30 minutes, you have to discard the vaccine. The Shingrix is given intramuscularly. It's a half milliliter, which is the same, if you want to think about this, as the volume you give, say, for a flu shot. You administer it immediately after reconstitution, or you store it in the refrigerator for up to 6 hours. So it has the advantage that because you can draw it up if you know you're going to be giving out the vaccine during the day, you can draw up a few doses in the morning and then give them all morning long and then do your second round in the afternoon. The Shingrix is different than the Zostavax in that it requires 2 doses rather than 1, and these doses are spaced 2 to 6 months apart. So for storage, this is part of what we covered in the polling question. The live vaccine has the storage in the freezer between 58 and 5 degrees for the powder, and the diluent is stored at room temperature between 68 and 77 degrees, or refrigerator between 36 and 46 degrees. You don't freeze the diluent, and you want to protect the vials from light because they can affect the amount of live virus. For the Shingrix, this is entirely stored in the refrigerator between 36 and 46 degrees. They're stored together all the way up until the reconstitution, and you also want to protect the vials from light. If you freeze this causes problems with the effectiveness of the vaccine, so you have to discard it if the vaccine has been frozen. Okay, for side effects. For the Zostavax, there are injection site reactions and in rare instances disseminated rash, herpes zoster in immunocompetent recipients, and life-threatening and fatal complications in immune-compromised recipients. Like I said, that is a rare outcome. These are generally pretty well tolerated, and they might get a little bit of a rash and discomfort at the site of injection. For the Shingrix, you get a sore arm with mild or moderate pain, redness and swelling at the site of injection. 1 out of 6 experience grade 3 side effects. This is 17% altogether, preventing them from doing regular activities. So grade 3 is defined by preventing doing regular activities. These symptoms do resolve on their own in about 2 to 3 days, and the side effects are more common in younger people. Patients might have a reaction to either or both doses of the vaccine, but folks who have reactions with the first dose, it hasn't seemed to blunt their willingness to come in for a second dose. This is a slide on notes from the field. So vaccine administration errors involving recombinant zoster vaccine in the United States. There are 155 reports to the VAERS system for adverse events, 8%. And I don't have a number for the number of VERP, but the following errors were described. For wrong route, Shingles was supposed to be given sub-Q, and it was instead administered IM. The wrong vaccine, they gave Shingles instead of varicella when it was intended. The wrong storage, it was improperly frozen. Shingles shouldn't be frozen. Wrong age, it was given to somebody that was under the age of 50, and it was given to somebody 39 to 48. Wrong schedule, Shingles given at wrong intervals or only one dose. It's a 2-dose series, administered 2 to 6 months apart, and there were reconstitution problems. Failure to reconstitute the vaccine and administration of only one component of the vaccine occurred. So that is VERP types of things. So, storage and administration requirements differ between the vaccine. It takes time to adjust the new vaccine techniques and procedures. I've heard from folks that I work with that they find the Shingles is easier to manage because it's all stored in one place, and there's the storage requirements, once they've reconstituted, are a little bit more lenient in terms of how much time you have to give it. If you have an adverse event, so this is a side effect, or a suspected side effect, that goes to the VAERS system. If there's an administration error, like I just described, that goes to the VERP or the Vaccine Error Reporting Program. There are website links that you can see on the slide. So now I'm going to go over the Advisory Committee on Immunization Practices recommendations. I'll refer to that as ACIP. So, the ACIP recommends the recombinant zoster vaccine, the Shingles, for the prevention of herpes zoster and its complications for immunocompetent adults aged 50 and older. The efficacy of this vaccine is over 90% across all age groups. So 50 to 69, it's 97%. 70 and older and 80 and older, at both of those cuts, it's more than 91%. It has a high efficacy, over 85%, 4 years out after vaccination. And that's really remarkable because compared to the live zoster vaccine, it is much better. There are serious adverse events between vaccinated and comparison groups. Grade 3 reactions are in 17% versus 3% in placebo. So that 17% is 10% of that is related to pain, and not quite as much as related to systemic symptoms. And I think I have another slide that goes over more of that, compared to 3% in placebo. So grade 3 is defined as reactions severe enough to prevent normal activities. So grade 3 injection site reactions are pain, redness, and swelling in 9.4% versus 0.3% of placebo recipients. And for systemic events, those are myalgia, fatigue, headache, shivering, fever, and GI symptoms. It's 10.8% versus 2.4% in placebo. So there's a similar proportion of local grade 3 after either dose, but there are more systemic grade 3 after the second dose. Most common solicited adverse reactions, grade 1 to 3, were pain. So 3/4 of the people that get this will report pain at the injection site, myalgia in about half, and fatigue in about half. These symptoms resolve pretty quickly within a day or two. The recombinant zoster vaccine is recommended for the prevention of herpes zoster and its complications for immunocompetent adults who previously got a live zoster vaccine. So the group that hasn't gotten the vaccine should get it, 50 and older. But if they've previously been vaccinated, you can still get it, and this will give you added protection. The RZV is more efficacious than the live vaccine in first year, all ages, greater than 50 years old, 97% for the recombinant vaccine, 69% for the live vaccine. These differences get to be larger the older you are. The recombinant vaccine maintains better than an 85% rate of prevention of zoster during the first 4 years for all ages. Studies indicate significant waning of protection from the live vaccine. So with the Zostavax, the vaccine effectiveness drops 15 to 25% in the first year, and by the time you're 6 years out, the vaccine effectiveness is less than 35%, and negligible protection out at 10 years. That is in contrast to the Shingles, the recombinant vaccine, where you still have 85% protection 4 years out, and we don't yet have data that goes as far as 10 years out. So for the ACIP, they say RZV, the recombinant zoster vaccine, is preferred over the live vaccine for the prevention of herpes zoster and its complications. And they give the qualification that these haven't yet been studied head-to-head, but the side-by-side comparisons are pretty stark. The RZV efficacy estimates are significantly higher than the live vaccine across all ages. So you can see 60, 69, 97% versus 64%, 70, 79, 91 versus 41, and greater than 80, 91 versus 18% in preventing shingles. This subunit vaccine appears to wane at a slower rate than the live vaccine over the first 4 years. The expected cases of herpes zoster and post-herpetic neuralgia averted are far greater for this recombinant vaccine compared to the live vaccine. Neither vaccine is associated with severe adverse events in immunocompetent persons, and the recombinant vaccine is more reactogenic than the live vaccine. So I apologize for the abbreviation in the above bullet, where I say HZ/SU. That is the same as the recombinant zoster vaccine. SU stands for subunit. The recombinant vaccine is a subunit. The subunit that they use is that glycoprotein E. On this slide, you see vaccine effectiveness on a scale of 0 to 100% on the vertical axis, and over time in years on the horizontal axis. The red line is the recombinant zoster vaccine with its 2 adjuvants, and the other line is the live vaccine. And what you should see is in protection against herpes zoster over the first 4 years, there's a huge difference in overall vaccine effectiveness. And you can see how, with the live vaccine, effectiveness continues to decline over time. In this slide, you can see projected cases per 1,000, getting no vaccine versus live vaccine versus recombinant vaccine. And what you should see here is that the no vaccine, you can see that the number of cases averted is present and much greater in the recombinant vaccine for all age groups. And for post-herpetic neuralgia, you can see the projected cases in no vaccine are in the 90 to 99 and 80 to 89. There's just not very many PHN cases. Jennifer, if you could open polling questions again. This polling question is, if an administration error occurs when vaccinating an individual, you should immediately report it to the Vaccine Adverse Event Reporting System, the Vaccine Error Reporting Program, or both. Jennifer, if you can open polling. I still don't see it open. I can't tell if I'm being heard. There it is. Okay. Please submit your answer. So as I explained before, the error reporting system is where you report administration errors, and side effects you report to the adverse event reporting system. If you see a skin reaction or something else and you're not sure it's because of the vaccine, you can still report it to the adverse event reporting system if you think it might be related. So in a moment we'll see the results. So the answer to this is vaccine event reporting system, and we got 60% that shows that. Still 24% weren't answering, so if you are, please answer. I would appreciate that. Okay, the next polling question, Jennifer, if you could reset that, please. Local or systemic side effects for Zostavax and Shingrix. First choice is have the same or similar impact on the individual. Zostavax side effects can be more impactful. Shingrix side effects can be more impactful. Please submit your answer. So what we went over was that the Shingrix causes more pain and systemic symptoms. 17% of them have moderately severe side effects. About half of that is related to pain, enough to keep them from being able to use their arm, and the other half systemic symptoms. So I would have chosen Shingrix as being the more impactful of the two in terms of local or systemic side effects. And again, we have about 30% not answering, but the majority who answered the question got it right, so congratulations. So two shingles vaccines are out there now. There's a killed vaccine and a live vaccine. One of the advantages of the killed vaccine is you can give it to immunocompromised patients who cannot take a live vaccine. And the ACIP has said that the recombinant Zoster vaccine is the preferred one, so they've given it a firm preferred recommendation. As a best practice, you want to integrate specific training into your practice on the new Shingrix vaccine. This is storage and adverse events and getting people to come for follow-up 2 to 6 months after that initial shot to get full protection. One of the things that we teach also for giving any other vaccine is when we recommend a vaccine, we want to make this a firm and positive vaccine. When the fall comes and you find people giving pushback for flu, it could be the way you presented the option. We recommend that the way you present this, for example, with flu or with Shingrix, it's time for you to get your fill-in-the-blank vaccine. We have one reserved for you if you're giving it, or there's one available for you at the pharmacy. This is something you should be getting now because you are now eligible. As opposed to, would you like to get your vaccine? Or what do you think about getting your vaccine? Or other things that sound that you don't have the conviction about the value of the vaccine. These vaccines prevent substantial morbidity, and in the case of other vaccines like flu vaccine, also mortality and hospitalization. So I think that's going to be an important part of your best practice of making a positive vaccine recommendation. An advanced discussion of side effects can help prepare patients in the event that they occur, and you already know that almost 1 in 5 of the people we give a Shingrix vaccine to, the recombinant vaccine, will have something that could take them out of work or keep them from doing things they would normally do for a day or two. So that's a remarkable number, yet it provides huge value if you consider that they have a 1 in 3 chance of getting shingles, which can be painful and inconveniencing down the road in their lifetime. So I want to thank you for joining me for this. I am open for questions in the chat line. I have to look at that in my window. There's resources here that you can click links to, ACIP recommendations. You can also Google ACIP recommendations shingles vaccine and find it. The VAERS reporting system you can also find just by putting the word VAERS reporting into Google, and it'll find this site for you, and Institute for Safe Medication Practices. So I'm going to work my way through some of the chat questions, and I want to remind you that if you have questions, you can enter them in the chat window. So you've heard some vaccine administration errors. Are children vaccinated for chickenpox at risk for shingles later in life? The answer is yes, but typically these appear to be milder. Even if you had chickenpox or you've had the varicella vaccine for kids, you should get a Zoster vaccination, either Shingles or live vaccine, and the ACIP recommendations for live vaccine sometimes age 50 or older. Let's see. How far apart should the fingers be given if previously received Zoster? I haven't seen any specific recommendations for that. What I am doing for my older patients, those that are under age 80, is I'm saying you can wait up to 5 years. But that is my own practice style for the ones that are older or have lots of underlying diseases. I think even a year out should be fine to give them that added advantage because of the greater influence of poorer immunity responding to the vaccine. It says you mentioned hepatitis as a complication of shingles. So what I meant to say was that when you get disseminated herpes virus, the herpes zoster virus in your body, it can go to other organs, including brain, liver, lungs, and thereby cause a pneumonitis or a hepatitis or a meningitis. I hope that clears up the question. So the virus can become disseminated throughout the body in people who are immunosuppressed enough. Will offering the vaccine be mandatory in the nursing home setting? So I can't anticipate what the ACIP will do for the nursing home setting. It is not likely that it will become mandatory, though is my opinion. I think it will come as recommended. I think it has issues in the nursing home that are different than younger adults. For example, if you're pushing a walker and you get a shot in your arm and for a couple of days you can't use your walker, it might influence your risk for falls and other kinds of things that might modify exactly how it's recommended for that setting or for which individual people. I think there are good workarounds, and certainly people in nursing homes have the highest risk of age-related subsets and getting shingles, so I think it is a population that where they should strongly consider getting the vaccine. The next question is, the chat window is scrolling too fast for me, so I got to back up a little bit. How far apart should the Shingrix, our pharmacy rep said Shingrix is not available as demand has exceeded supply. I've heard this also, and I know that GSK, the manufacturer for Shingrix, is working hard to catch up. If somebody is anxious about getting protection against shingles, the live vaccine is still available, and they could use that as a way to protect them initially while they wait for the Shingrix supply to catch up. If someone had the live vaccine 10 years ago, should they now get the recombinant vaccine? If they're over the age 50, I would say yes. Would Shingrix be recommended for short-term care residents if they are not expected to be here for the second vaccine? So I think that's an interesting question. Certainly people who are in short-term care are currently being stressed for the reasons that they're in short-term care for. There are reimbursement issues with that vaccine to the nursing home, which is operating under Part A. So I don't know how the coverage for the cost of the vaccine would be. It would make sense to me that if they're interested in the Shingrix, that they get it upon discharge from skilled care. Unless they're planning on becoming long stay, then that would be a fine time to give them the vaccine. If they want to make sure that the cost gets shifted to their insurance, waiting until they're off of Part A is a reasonable thing to do to help manage costs. Let's see. In an older adult who has had shingles in the past, would the new Shingrix work to help protect them from further outbreaks? So it is true that once you had shingles, it doesn't necessarily protect you from future shingles events. So getting a Shingrix or live Zoster vaccine are both ways to prevent future shingles risk. If the ACIP were to speak to this, and I can't actually speak for them, but my suspicion is that they would be recommending Shingrix over the live vaccine because of its greater effectiveness. What if the individual who's vaccinated doesn't come back for the second dose? If they eventually return, but it is past 6 months time period, does the first dose need to be administered again? We don't actually have guidance on that. My suspicion is that if they get the second dose, a year later or even 2 years later, that will still boost that primary inoculation. We won't know for quite a few years whether their protection is going to be comparable to if they had gotten them both in that tighter window. It is reasonable to assume that that second dose will get them close to that level of protection, even if it doesn't get quite as high. If you miss, there's a second question that's similar. So you don't have to start the process over again. At least that's how we currently do it. Is it okay to get shingles vaccine for those who already had shingles? I answer that yes. Do the systemic effects of Shingrix ever last longer than a few days, and can they be permanent? I'm not aware of anybody who's had permanent side effects from the Shingrix vaccine. And there are some people who have some of the symptoms lasting more than 2 or 3 days, but that is rare. Are you learning there are obstacle barriers with payment options for Shingrix? So the adoption by the insurance companies to cover this is rapidly changing. They have not yet all adopted paying for this, but I think that will change over the next year or two. There's a question about the copays. I don't actually know what the copays are, but this vaccine, individual doses, I think, are a little less than Zostavax, but the combined 2 doses, I think, cost more than Zostavax. Don't quote me on that. I think that's how it is, though. For disseminated virus, are there tests which can be performed to determine if the virus had spread elsewhere? There are tests, and yes. I'm not sure that one would need to do those tests. If they had shingles and they had concurrent evidence of new symptoms from another organ, say liver or lungs, then I think presumptively the differential would include spread to those organs. If they had DIC, having herpes virus in the differential as the etiology of that DIC would make sense. Please review isolation required for healthcare workers caring for patients with shingles. Why is it harmful for pregnant women and those not having had chickenpox? So the same virus that causes chickenpox causes shingles. In people who have chickenpox, the virus is spread through the air. That airborne spread means it's highly contagious if it's chickenpox. Shingles is spread almost exclusively through contact. So the virus gets on clothing and on surfaces and can survive there for quite a while. So women who are pregnant are immunocompromised, and at the time they're pregnant, especially if they haven't previously had chickenpox, they run the risk of becoming infected the first time, and if they get infected for the first time to get chickenpox, they will be much sicker than if they had gotten it as if they had gotten it when they were children. So the fluid that's in the vesicles has live virus, and that can spread to others through direct contact. Let's see. What population should be prioritized to receive the Shingrix during the shortage? I would say the most at-risk population should get it first. So if you don't have enough, I would give it to the 80 and older first, and then work my way down to younger populations as it becomes more available, because the populations at highest risk for getting shingles should be the ones that get priority. There's a question, repeat please. If I had shingles before, do I get the live vaccine or the recombinant vaccine? I would recommend the recombinant vaccine as the vaccine of choice. And if it's not available and you were worried about in the near term of getting shingles, the live vaccine could carry you over to get your protection until the recombinant vaccine became available. Is it true that administration of the vaccine will be covered if given at the pharmacy versus a physician's office? There are, it depends on your insurance carrier exactly how it's paid for. So folks that are younger who may have employer insurance may have different coverage benefits than the ones that are older that might be on Part D and Part B. And it's not clear to me, I know there was discussion about which Medicare insurance it should be under Part B's and boy or D's and dog, and I don't know where they have finally landed on that. Will this webinar be recorded for those who missed it? I believe it is, but Morgan can tell us afterwards when I hand it over to her. Should someone get Shingrix if they had Zostavax in the past, even if they haven't had shingles? I'm wondering if it would help protection in their future. The answer to the question is if you've had shingles or if you've had the live shingles vaccine, Zostavax, in both cases, there is a ACIP recommendation that at some point you get the recombinant vaccine with the adjuvants, the Shingrix, in the future. This is for anybody that's age 50 and older. And I know there are some folks that are starting to give it to immunocompromised people at a younger age, but that is outside of its labeling. And usually when they do that, it's because they have HIV or some other thing that puts them at high risk for getting shingles. Disseminated, is it airborne as well? So when they have disseminated shingles, the risk that they might be breathing it out through the lungs, I believe, is slightly greater, but I am not aware of any literature that definitively reports on whether there is an airborne risk that's different. It would be my suspicion that it could be, but I don't know that it is. Morgan put a response back in the chat that this webinar is recorded and will be posted to the event webpage along with the slides and a transcript, and the link is given there in the chat box. You mentioned that shingles survives for quite some time in the clothing. Does washing kill the virus? How can we prevent it from spreading to family members? It can survive yes, if you put it through the laundry, that'll take care of it. If you certainly bleach on surfaces will kill the virus. Ultraviolet light will kill the virus. It lasts longer on slick surfaces than other surfaces. Doesn't spread as easily from cloth surfaces because it adheres to things. There is a statement here that it says, I need to report vaccines to CMS, QPP, MIPS, CCM. Do I report either vaccine and to where? So I think one of our other QIO folks can talk about QPP, MIPS reporting. And with this, I'll hand it back over to Morgan, who might be able to answer that question. Hey, Morgan.
Dr. Gravenstein.
Thank you.
Morgan, are you on?
Yeah, I missed that. What was the question?
There was one of the last chat questions was, and I don't know if there's somebody on the line that might know the answer to this, had to do with reporting to CMS, QPP, MIPS, CCM.
I actually do not know that information. I'm on the communications team, but Sharon, I can take your information and share it with our QPP team, and one of them can get back to you.
Great questions from the group. I thank you so much for joining us and posting your questions. And Sharon, thank you for sending your email address.
Awesome. Well, thank you guys for all those excellent questions. And yes, Sharon, we will make sure that I get you in contact with some folks that can help you out. Just a few announcements before we end today's call. We are now on social media. Oh, we did questions. We're now on social media, so follow us there for the latest alerts, news, events, and more. If you haven't yet checked out our Learning Center, it's our virtual learning system which hosts free courses for all healthcare settings. Our goal with this is to educate providers and help them improve the quality, efficiency, and value of healthcare. So the information is on the slide on how to find it. You can access it at learningforquality.org. And then if you have any questions or difficulties with registering, the email address at the bottom will be able to help answer any questions that you have. As you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we'd greatly appreciate it. If you don't have time to fill it out right now or you're sharing a computer with someone, you will receive a link in an email tomorrow that will take you to the evaluation. In that email, we'll also include a link to the event webpage, which we have posted in chat a few times, but just in case you need it again, where you'll be able to find the PowerPoint presentation, and then within the next few business days, as Dr. Gravenstein mentioned, we will add the recording and transcript. So thank you again for attending. Thank you, Dr. Gravenstein, for that great presentation, and we look forward to having you on a webinar soon. Have a great day.